Welcome to the Australian Dental Council 2026 Explainer podcast.
Glad to be here for this one.
Yeah, today we're not just reviewing theory, we are shifting gears into a full-scale simulation.
Exactly. I think that's the absolute best mindset we can have for this deep dive.
Right, because this isn't about just memorizing a textbook definition. It's really about standing in that exam room, feeling the pressure, and knowing exactly what to do.
Yeah, knowing how to react. We're taking a pretty big stack of clinical notes, OSCE case studies, and some really dense research on resin infiltration.
And we're going to use all of that to turn you into an expert on a single, fairly complex clinical station.
The mission is simple, right? Get you ready to walk into that room, see the patient, and just nail the diagnosis and treatment plan without hesitation.
Without missing a beat. So let's look at the source material we have today. What is the specific scenario we're breaking down?
Well, we're tackling a classic aesthetic dilemma, but I really want to frame this as a masterclass in conservative aesthetic dentistry.
Conservative being the key word there.
Very much so. The ADC examiners, they are looking for a highly specific philosophy. They want to see that you can solve a major aesthetic problem without picking up a high-speed handpiece unless you absolutely have to.
Which honestly is a huge mental shift for a lot of candidates who are just so used to drilling.
It is. It goes against instinct sometimes.
So let's meet the patient in our scenario. Our sources introduce us to Maya. She's a 17-year-old female. She walks into your clinic and, well, she is visibly distressed.
Maya is the quintessential aesthetic case for the OSCE. She's young, she's highly self-conscious, and her chief complaint is...
It's heartbreakingly specific, honestly.
It really is.
I have her quote right here from the case notes. She actually says, "I hate my smile. These white and brown spots on my front teeth make me look like I don't brush, but I brush 3 times a day."
Yeah, and that statement right there, that is your very first diagnostic clue.
The brushing 3 times a day part.
Exactly. I brush 3 times a day.
Yeah.
She is outright telling you this is not hygiene-related, it's structural.
Right.
And psychologically, she's telling you that she perceives this as a stain on her character, not just her teeth. She thinks people look at her and see dirty, even though she's doing everything right.
That is just a really heavy burden for a teenager to carry.
Absolutely.
And looking at her social history, the notes mention she grew up in a region with high natural fluoride in the well water.
A huge red flag for the diagnosis.
So let's visualize the clinical presentation based on that. When Maya smiles, what exactly are we looking at?
You're seeing bilateral, symmetrical white opaque lines and areas of brown staining on the maxillary incisors. But here is the crucial detail.
The one that changes everything.
The one that decides your entire treatment plan. There is no pitting. The surface is completely intact.
Okay, so we have white and brown spots. They are symmetrical, and we have a smooth, intact surface. Combined with the history of well water, the diagnosis seems pretty clear-cut. Moderate dental fluorosis.
Correct. But, for the ADC, simply saying moderate fluorosis is not going to get you full marks. You need to be far more precise.
Right. They want the specific grading.
They do. We're looking at a Thilstrup and Fetcherskopf index score of 4, or TF index for short.
Okay, we definitely need to unpack the TF index because those numbers seem to dictate everything that follows in the treatment plan.
They map the whole route.
But before we get into the grading numbers, let's talk about the visual diagnosis a bit more. You mentioned symmetry. Why is symmetry the gold standard for fluorosis?
This is all about pattern matching. Fluorosis is a systemic developmental issue. It happens when the teeth are actively forming, usually between 20 and 30 months of age.
When the enamel is being laid down.
Exactly. Because the excess fluoride is in the blood supply, it affects the ameloblasts, the enamel-forming cells, on both sides of the arch simultaneously.
So it's perfectly mirrored.
Basically, yes. If you see a white spot on tooth 1-1, you must see a near mirror image on tooth 2-1.
Okay, so let's play devil's advocate for a second. If I'm a candidate in the exam looking at a patient, and I see this big white blotch on the right central incisor, but the left one is perfectly clean.
You can rule out fluorosis almost certainly.
Really? Just like that?
Just like that. That asymmetry leads us straight to the main differential diagnosis, which is molar incisor hypomineralization, or MIH.
The MIH, the imposter in this station.
MIH is absolutely the imposter, and mixing them up is an instant fail.
So how do we clearly distinguish them in the heat of the moment? What's the visual cue?
I want you to visualize a split screen. On the left, you have fluorosis. It's symmetrical, it's diffuse, and it often looks like fine horizontal lines tracing the parenchyma.
The growth lines of the tooth.
Right. It fades softly into the healthy enamel.
Like a cloud.
Like a cloud, exactly.
Yeah.
Now, on the right side of your mental split screen, you have MIH. These are asymmetrical, well-demarcated opacities.
The sharp borders.
Very sharp. They look like random aggressive blotches of cream, yellow, or brown. And critically, MIH typically hits the first molars and maybe just one or two incisors, not the whole dentition evenly.
It's chaotic.
Highly chaotic.
That's a really great visual. Symmetrical clouds and lines, tracing growth versus random sharp blotches. That makes it so clear.
It's the very first thing an examiner will look for in your reasoning.
Okay, now let's go back to the numbers game. You said Maya is a TF4. Why does that specific number dictate the entire treatment plan?
The Filstrip and Fudger-Scov index is brilliant because it correlates the visual look with the actual histology. It tells us what's happening under the microscope.
It tells us how deep the problem really goes.
Exactly.
So walk us through the levels that are relevant to this case.
Sure. So TF1 and 2 are mild. You see thin white lines, often called snow capping on the cusps.
Barely noticeable, right?
Very barely. Honestly, most patients don't even complain about it. But then we get to Maya's level, which is TF3 and 4. This is where those lines and opacities merge.
So the tooth just looks chalky.
Yeah, chalky or cloudy covering the whole surface.
And physically, what is actually happening to the enamel at a TF4?
There is significant subsurface porosity. The enamel structure underneath is just full of holes, microscopically speaking.
Like Swiss cheese under the surface.
Exactly. But, and this is the absolute key for the exam, the outer enamel surface is still physically hard and intact.
So the problem is entirely under the skin, so to speak.
Entirely. And because the surface is intact, we can treat this chemically and optically. We do not need to cut the tooth.
Which the ADC love.
They demand it. But then we hit the tipping point, which is TF5.
What changes at TF5?
Pitting. At TF5, the subsurface is so porous that the outer enamel actually collapses during function. You get actual physical holes or pits in the surface of the enamel.
The armor has essentially been breached.
The armor is broken.
And I assume that completely changes the rules of engagement.
Completely. Once you have physical loss of enamel, that pitting, you can't just infiltrate it with resin anymore. You have a structural defect.
So you have to restore it.
Right. Your treatment plan must shift toward composite restoration or veneers because you literally have to replace missing tooth structure.
That is such a critical distinction for the candidate to make. TF4, you treat the color. TF5, you treat the structure.
Beautifully put.
Since Maya is a TF4, we are staying conservative. But before we discuss the actual fix, I really want to understand the science here.
Let's do it.
Why do these spots look white in the first place? Is it just the physical color of the fluoride itself?
No, and this is where the science gets really fascinating. It isn't a stain in the traditional sense, like coffee or red wine on a tooth.
So what is it?
It's an optical illusion caused by physics.
Yeah.
All comes down to the refractive index, or RI.
Refractive index. Wow, that takes me straight back to high school physics.
Bear with me, because this completely explains the magic of the cure. Light passes through different materials at different speeds. Healthy, solid enamel has a refractive index of 1.62.
Okay, 1.62.
When light hits it, it travels through smoothly, which is what makes the tooth look translucent and alive.
So 1.62 is the magic number for a healthy-looking tooth.
Right. But in fluorosis, you have these subsurface pores we just talked about.
Yeah.
And what's inside a pore?
Air or water.
Exactly. Air has a refractive index of 1.0. Water is roughly 1.33.
That is a massive deviation from the 1.62 of healthy enamel.
It is. And when light hits that boundary between the solid enamel and the air pocket, it scatters. It bends and reflects back.
And that scattering is what your eye perceives as an opaque white spot?
Precisely. The tooth structure is actually there. It's just full of tiny air pockets that are scattering the light, preventing us from seeing through it.
It's like looking into fog.
Fog is a perfect analogy. The water droplets scatter the light. So how do we fix it? We can't easily remineralize those deep pores to make them completely solid again. The technology isn't quite there yet.
But we can cheat the physics.
We can absolutely cheat the physics. This is where resin infiltration or the commercial product icon comes in.
This is what our sources refer to as optical masking.
Yes, the resin used in this procedure has a refractive index of 1.52.
1.52, which is remarkably close to healthy enamel's 1.62.
Exactly, it's a near perfect match. If we can get this liquid resin to soak deep into those air-filled pores, we replace the air, which is 1.0, With resin, which is 1.52,
And the light just stops scattering.
it stops scattering.
Okay,
It passes through almost exactly like it does in healthy enamel.
I really like the analogy you used in our prep notes about the sponge. It made this entire concept click for me.
It's definitely the best way to visualize it for a patient. Think of a dry kitchen sponge. When it's totally dry, it looks opaque, light-colored, and you obviously can't see through it.
Right.
That dry sponge represents the porous fluorosed enamel. Now, take that sponge and throw it in a bowl of water. It turns darker, it becomes somewhat translucent, you can almost see your hand through it.
Because the water filled all the little air pockets.
Exactly. Resin infiltration is basically like filling that sponge with water that never dries. We are optically masking the lesion.
That is amazing. So the white spot is technically still there structurally.
We haven't removed any enamel.
Right, but you physically can't see this spot anymore.
You've hidden it in plain sight.
I love that. Water that never dries. Okay, so we know the diagnosis is TF4. We know the physics with the refractive index. Now we are actually in the exam room.
Hot seat.
The hot seat. The examiner asks you for the treatment sequence. You obviously can't just say, put resin on it. What is the specific ADC protocol?
It is a very strict phased approach. The ADC wants to see you managing risk. You never just jump straight to the hardest step. Phase 1 is always professional bleaching.
Wait, I have to challenge that based on the visual. If the spots are bright white, won't bleaching make the rest of the tooth whiter and the spots still white? Or even brighter?
That is a very common misconception, actually. Yes, the spots are white, but usually the background tooth structure is a bit yellow or darker, which creates high contrast.
So they pop more.
They pop. By whitening the whole tooth, you raise the value, the brightness of the surrounding enamel. This massively reduces the contrast. The white spot just blends right in.
So it lowers the noise of the spot.
Exactly. But there is a massive trap here for the exam candidate. If you prescribe bleaching, you absolutely cannot bond resin immediately.
Why is that? What happens?
Oxygen. Bleaching works by releasing oxygen radicals into the tooth structure. And oxygen severely inhibits the polymerization of resin.
Oh, wow.
Yeah, so if you try to do resin infiltration the day after a bleaching treatment, the resin just won't cure properly. It will fail, and you'll have a clinically compromised mess on your hands.
So what is the exact rule we need to state out loud to the examiner?
You must state clearly, I will wait 10 to 14 days after bleaching before proceeding to resin bonding.
10 to 14 days.
If you miss that window, you risk a total clinical failure.
Got it. Okay, 10 to 14 days. Phase 1 is done. Now, phase 2. The notes mention microabrasion. When exactly do we use that?
This is specifically for those brown stains Maya has. Bleaching fixes the yellow, but the brown requires mechanical removal. For this, we use a slurry of 6.6% hydrochloric acid and silicon carbide.
Silicon carbide, isn't that essentially just crushed rock?
It is. It's a microabrasive. It's like sanding a floor, but microscopically. You rub it on to physically remove that very superficial stained layer. It's aggressive, but highly controlled.
Okay, and if that removes the brown, but the white spots still remain?
Then we move to the main event, phase 3, resin infiltration. And for the OSCE, the step-by-step detail here really matters. Step 1 is isolation.
Rubber dam?
Mandatory. We are about to use 15% hydrochloric acid in the mouth. That is strong stuff. You do not want that anywhere near a patient's gums, and they definitely shouldn't swallow it.
15%. Standard etch for a normal composite filling is usually, what, 37% phosphoric acid? Why are we switching to hydrochloric acid here?
This is a key technical detail that candidates miss. Fluorosed enamel is weird.
Yeah.
The surface layer is actually hypermineralized. It's incredibly hard and highly resistant to acid.
It acts like a shield.
It does.
Yeah.
Normal phosphoric acid just can't penetrate it effectively. So we use the Icon etch, the 15% HCl, to erode that surface cap and actually open the pores underneath. And here's a major nuance for top marks. For fluorosis, you often need to etch multiple times.
The instructions usually say 2 minutes, right?
For normal post-orthodontic white spots, yes, 2 minutes. But for fluorosis, because of that hypermineralized shield, you might need to etch, rinse, and repeat for up to 15 or 20 minutes total to finally break through.
Wow, 20 minutes of etching. You really have to be patient.
Very patient.
Okay, so we've etched, we've rinsed. Now comes what looks like the most dramatic part of the procedure in the videos, the alcohol trick.
The diagnostic window. This is the absolute aha moment in the chair.
Explain how it works, because it's fascinating.
So after etching and drying, you apply the Icon dry solution, which is basically just pure ethanol. Ethanol has a refractive index much closer to enamel than air does.
Okay.
When you wet the white spot with the ethanol for a few seconds, the liquid completely fills the pores.
And what happens visually?
If you've etched deep enough to open the pores, the white spot should disappear right before your eyes. It should suddenly look exactly like the surrounding healthy tooth.
That's incredible. It's like a crystal ball.
Exactly. It tells you the future. If the spot disappears with the alcohol, it guarantees that the resin, which flows just like the alcohol, will also make it disappear permanently.
And if it stays white while wet with the ethanol?
Then you haven't etched deep enough, the pores are still sealed off. You need to rinse the alcohol, dry it, and etch again with the HCl. Do not apply the resin until that alcohol test works.
That is such a critical clinical tip. It stops you from wasting the really expensive resin on a case that isn't prepped yet.
Precisely.
So once we get the disappearing act with the alcohol, we finally apply the resin.
Yes, the infiltrant. It has a very low viscosity. You just let it sit for 3 minutes. Capillary action literally sucks it deep into the tooth, and then you light cure it.
Fantastic. So we've gone from I hate my smile to a beautifully treated case without ever using a drill.
A massive win.
It is. But I want to circle back to something you mentioned right at the start, the death spiral.
The restorative death spiral. It sounds dramatic, I know, but it is very real.
We're talking about the long-term impact here. Maya is only 17 years old. Why shouldn't we just give her veneers? They look perfect, they're super fast, and let's be honest, patients often come in specifically asking for them. Why is the ADC so fundamentally against it?
They're fast for you as the clinician, but they are a lifetime sentence for her as the patient. You have to think about the math.
Okay.
She's 17. If you cut her pristine enamel for a veneer, that veneer has a lifespan. Maybe 10, 15 years if she's really lucky and takes perfect care of it.
So by the time she's, what, 32?
She needs them all replaced. And every single time you replace a restoration, you lose a little more healthy tooth structure. The prep gets deeper. The pulp gets more irritated.
And then at 45?
Maybe she needs a crown. Then maybe the nerve dies and she needs a root canal. Then maybe a root fracture and an implant.
The spiral.
That is the death spiral. You start at the very moment you pick up that burr on a 17-year-old.
And the ADC is just obsessed with preventing this,
Right?
right?
Absolutely obsessed. Preserving enamel is considered a legal and ethical obligation in Australian practice. If you propose veneers for a TF4 case on a teenager, you are outright failing the safety and ethics domain of the exam.
You are overtreating.
Grossly overtreating.
It's really interesting because we actually have data on the psychological impact of this conservative treatment.
Yeah.
The sources mentioned the Oral Health Impact Profile, or OHIP-14.
Right. This is a scale that measures how much a dental condition negatively affects a patient's daily life. Patients like Maya often come in with a very high score, around 23, which indicates severe distress.
And after treatment,
Studies show that treating these spots conservatively, just with resin infiltration alone, can drop that distress score all the way to zero. Zero, meaning the patient is completely happy, the social anxiety is entirely gone, and you achieve that life-changing result without removing a single micron of healthy tooth structure.
That is the ultimate definition of success in the eyes of the ADC.
Exactly. You fix the problem without creating a future patient for the prosthodontist.
That really drives home the importance of this whole technique. So we've covered the diagnosis with the TF index, the science of refractive indices, the specific step-by-step protocol, including the alcohol test, and the ethical obligation to stay conservative. We are coming to the end of our deep dive.
But before we sign off, I know you want that one final hot tip for the OSCE.
You know I do. Give us the nugget that makes the examiner look up from their clipboard and nod.
Okay, here it is. This is pure Australian local knowledge. Since this is the ADC, you need to prove that you understand the Australian public health context regarding fluoride.
What's the specific stat we need to drop?
Water fluoridation levels. You need to explicitly mention that in Australia, the target range for fluoride in drinking water is 0.6 to 1.1 milligrams per liter, or parts per million.
0.6 to 1.1.
Right. If you drop that specific range while taking the patient history, maybe by asking, did you grow up in an area where the water fluoride was above the Australian standard of 0.6 to 1.1, you're showing that you aren't just a clinician.
You're an Australian practitioner.
Exactly. You understand the local baseline public health measures. Examiners love that.
That is absolute gold. 0.6 to 1.1. Everyone listening, write that down.
And I have a final provocative thought to leave you with. Something to chew on.
Let's hear it.
We've spent this entire time talking about how to fix fluorosis, how to hide it, mask it, make it go away.
Because it's an aesthetic defect.
Visually it is. But biologically, Fluorosed enamel, that hypermineralized surface shield we talked about, is actually significantly more resistant to acid than normal enamel.
So, wait, it's actually stronger against cavities?
In a lot of ways, yes. It's an aesthetic curse, but a biological shield.
Mm-hmm.
Maya's teeth, despite how they look, are probably much less likely to get decay than yours or mine.
That is
It
wild.
raises a big philosophical question for us as dentists. Is our modern obsession with the perfect, uniform white smile leading us to pathologize a tooth that is actually evolutionarily superior in a high-sugar world?
A biological shield? I don't think I'll ever look at a white spot the exact same way again. That is a fantastic place to wrap up our ADC fluorosis explainer. We really hope this deep dive helps you crush that station.
Keep it conservative, trust the chemistry, and always remember the alcohol test.
Thanks for joining us on this deep dive. Good luck with your prep.